I am Julie Rovner, with the Chief Washington Correspondent at Kaiser Health News. We actually live upstairs here. And I want to thank everyone for being here. And I want to thank this esteemed panel, who I will now introduce. Here to my right is Steve Beshear. He's the former Democratic governor of Kentucky. During his tenure, he launched one of the most successful state-based exchanges and expanded Medicaid, providing coverage to roughly 500,000 Kentuckians and seeing the state's uninsured rate plummet from 20%, one of the highest in the nation, to 7.5%, one of the lowest. To his right, to his right is Senator Bill Frist, former heart and lung transplant surgeon, so a provider, Republican senator from Tennessee, and Senate Majority Leader, among many other accomplishments. And finally is Sandra Hernandez. She's president and CEO of the California Healthcare Foundation. She's the former public health director for San Francisco and one of the founders of the groundbreaking Healthy San Francisco program, which predated the ACA. So I'm going to chat with these folks for about a half an hour, and then we will turn it over to you for your questions. I will remind you when we get there, but please tell us who you are, and please make your question a question. First, I would like to ask each of you this question. What would the U.S. look like with everyone able to afford quality health care? This, if you look around the world, can see this can be done in a myriad of ways. If you could wave a wand and make it happen, what would your utopian health care system look like, Governor?
Well, being on the board of the United States of Care, I would say it would look like the implementation of all the principles that all of you all saw this morning. But you know, as a former governor, I'm not much of a magic wand person because it doesn't work in terms of getting anything done. I think that's one of our problems is that so many of us get wrapped around the axle with ideology and the magic wand solution that we lose sight of the practicalities and the pragmatic things that we need to do to try to move the ball forward. And that's what governors do, at least the successful governors do. You know, and when the ACA came along, you know, here I was in Kentucky where President Obama had a 30% approval rating. That was going to be exciting for me. But I decided to implement the ACA and expand Medicaid because to me it was the right thing to do. And I always say I had a two-part decision-making process. I tried to figure out what the right thing to do was, and then I tried to figure out how to do it and survive. And so we decided to do it. We took every dollar the feds would give us to plan. And I figured out that the word Obamacare was a curse word in Kentucky, so I changed the name to Connect. And I still remember the fellow, you know, trying to sign up at the state fair, and I was listening, and he ended up saying, "Oh man, this is great. This is a lot better than that Obamacare." But you know, he signed up, and so we implemented that, and what we see today. Because of, I think, the practical ways that we did it, is that Kentuckians generally still don't like the phrase Obamacare, but they sure don't want anybody taking their health care away from them. And, you know, so I would come back to, you know, it's time for us to kind of put aside our magic wands. And, I mean, the senator knows very well what I'm talking about because he's tried to herd the cats up in the Senate for years. And you've got to find some common ground, and then, like we're trying to do with this organization, and let that bubble up and become kind of the genesis of where we go from here.
Senator, you've seen this obviously as a provider, as a legislator. Now you're working in the private sector. I mean, what would the goal be? What would it look like when we achieve a state of a functional healthcare system with everyone covered?
You know, that I think it's a fundamental question to ask, and it's a great one to start with. And if everybody had better health care, people would be healthier, greater well-being, dreams would come true, people would live longer, more fulfilling lives. But if it's just affordable health care for everybody, the world wouldn't change very much. And I say that, I'm a surgeon, and I like to think taking people's hearts out, moving around makes a big, big difference. And they do live longer, and they live happier, and they see grandchildren grow up, and it's a great technology that is now pretty routine. But, and this is what was good about this morning, to have affordable health care for everybody is just not enough. And it comes back to the basics that we all know, that if we fix all that, that's maybe 15, maybe 20% of happiness, well-being, health, not health care, health, and well-being. And so as people throw in the word social determinants, and we talk about food and housing and where people live and culture, which we'll talk about later. So the way you phrase your question, not very much. And until you link the 15% impact of our healthcare system and Obamacare and universal insurance and access and affordability to the 40% of behavior and the 10% of environment and climate, and that gets you in a lot of areas, until we link all of that, it's not going to change the world as much as we would like to think. So the social determinants, which we'll come to later, have to be linked to it inextricably, which may not apply to affordability for everybody. It's more than that.
Well, thank you for the question. Nice to be here. I'm not going to take the wand either. But I will say this, and maybe this comes from living in California, where we can see our way potentially to getting everybody covered. I do think we as a country can get everybody covered. And, you know, with a combination of leadership in state houses, a ton of innovation, a secretary who's interested in moving into different forms of payment, all the innovations we've seen in different states. So I actually think we will get to universal and should get to universal. And then it's worth noting, as the senator alluded to, what we don't spend in social services, if we compare ourselves to any of these European countries that cover everybody and that have much, much better health outcomes and are much healthier than our populations are, we really need to think about where those dollars get invested in prevention, in population health, and all the things that we know contribute to the things we see that are then expensive to care for on the back end. So I think, though, and this was the principle behind the ACA, which was you got to get everybody covered first and then go to affordability. And that affordability should be in part, where do we reinvest that on the prevention side and on social determinants of health?
So I want to come back at that, because the principle, you're right, when they were doing the ACA, the idea was we can't take care of cost and structure and everything else in the system until we get everybody covered. A lot of the pushback was, no, we have to figure out how to get control of costs before we can cover everybody, which we're now at sort of another tipping point. Do we have to get costs under control before we cover everybody else, or do we need to cover everybody else before we get costs under control?
Well, let me just say this, and it was one of the tenets I think Andy spoke to this morning, and that is if you look at the long game, there is no investment that we make in prevention that we get an ROI the next year, or that the CBO is going to be able to mark up the next year. And so and by the way, we eviscerated most of the prevention and community-oriented services that were built into the ACA. We have to have a long game if we're going to benefit from that prevention. And we also need to start much earlier. We need to really think about, you know, prenatal care all the way through, home visits, you know. So I think we've been impatient with the principles in ACA that would have brought us much more in relationship to prevention and to some of the community services that were originally envisioned in part of the ACA.
Senator, do we have to do something about costs before we can cover any more people?
No, I think it was a huge mistake for our country to go in a direction of just access. I'm for universal access, affordable universal access. But, and people will come back and say, yes, but we had a lot of cost provisions in there. But if you really step back from a legislative standpoint of having to watch the way things were done, I think it was a huge mistake, just going with access itself. And the pushback today from people where I live, where the governor lives, is just that. You know, the access is okay, but if I still can't afford it, I don't have the access itself. So that was a mistake, and I think most people will recognize that. So it has to be done in a dual way. We have to do everything we can for affordability, but neither is going to work if it's going to be one versus the other. And we may be swinging too far the other way right now as well, but it's got to be a dual approach. Every conversation has to be a dual approach. And when you're talking to real people, patients at the dinner table, which is the focus of very much of what we're doing, they will tell you just the same thing.
Yeah, you have, out there today, the folks on expanded Medicaid, they are, in my state at least, relatively happy in that they've got coverage for the first time. And the emphasis on wellness and prevention, has really, while we all know you can't really measure this thing for 20 years probably in terms of better health, you can look at some short-term determinants like screenings. And our screenings went through the roof in Kentucky. Every kind of cancer screening, cholesterol, diabetes, blood pressure, whatever, it went through the roof. And hopefully what that means, obviously, is that you find out about the disease or condition early, you teach people how to manage it, and therefore in the long run you're going to save some money, or at least keep the cost curve from going up as rapidly as it's going up. But you've got another set of people out here who, some who are getting subsidies that, with the way the premiums have gone up, it's not sufficient for them to afford anything. And then the folks that are just above qualifying for subsidies are getting killed. And there's a variety of reasons for that, I'm sure, but the fact is they're looking around going, oh my gosh, I want this too, but, and it's kind of reverberating back down, and people are saying, well, they're getting it down here at the Medicaid level, and how come I can't even afford anything? So we've got to address this cost thing, I think, as well as the access.
You may be sort of getting to my next question, which is, I get that you're not all wand people, but I think the object of this panel is to talk about a path to sort of get us to the goals. What would you do first if you could sort of do one thing that would sort of start a glide path to?
I think there's one idea out here that's being utilized in a number of places, but we need to utilize it a lot more, and that's paying for quality as opposed to quantity. The fee-for-service model would break us all if we kept to that. I took our Medicaid program even before I expanded Medicaid, and I actually did it for budget reasons. I became governor at the end of 2007, and guess what hit about that time? The Great Recession. And our revenues actually went backward. I mean, we had less money the next year to spend than we were currently spending. So we had to do something, and part of what I did, as opposed to cutting benefits, is that we took about 80% of our Medicaid system to managed care in an attempt to try to, use capitation and all of these things to start controlling cost. And I'm sure there's myriad ways of doing it, but to me, us beginning to pay for quality as opposed to quantity is just a must.
Senator Frist, first thing.
I agree. We saw the pendulum switch with this administration away from value-based care with the initial secretary for HHS, and then now swinging way back towards it, which is really fascinating to me.
And it's not so much if you're a provider.
Yeah, no, exactly right.
Bundled things.
That's what that was. I would have cared when I was doing the heart surgery back then. But so the value-based care, I think, is the direction to go. Where we are in this climate, where we have a president in particular who's not focused on health care, it's probably a good thing that he's not. but because we have some good people working to figure things out without being slapped down. But I think from a practical standpoint, value-based care is good, so you get a little bit of bundling in, and you kind of move to the directions you can at the policy level. The states will be, as we talked about this morning, have the opportunity to innovate a lot more. And in the social determinants area, putting what really is value to determine outcomes, and not just paying for things, and not just saying, here's a doctor, because it's so much more than that. So the innovation at the state-based and local level of incorporating social determinants into the acute delivery and preventive care and the like. So that's one thing that I'm encouraged about. Number two is what I would do is start, and what I do in my own mind is start where you can pull, and this is politics in me, where you can pull Republicans and Democrats together around a common message they both care about, both have buy-in outside of the political realm of partisanship. And one area is end of life. And we saw it in hospice 30 years ago. We have so much to learn from other countries, which, as Andy talked about today, other countries are doing great things. The hospice arena, which had its origins pretty much in Europe and in England 100 years ago, Took us 70 years to learn. We learned it. It was implemented here. It's executed on. Very successful. And that's really the last 2 weeks. It should be the last 40 days, the last 2 weeks of life. But again, there's a great common ground in the palliative health care world, end of life. We're going to all be there. All 350 million people of us are going to be there. We have more than one disease. It's going to go over a long period of time. Use that as a model to put value-based care, wrap teams around those people, get the cost down, because it doesn't have to be expensive if it's chaotic fee-for-service. The cost comes down if you wrap a team in a value-based system. And build out from that model. So you did hospice, you do palliative health care, you can do sort of more senior type chronic disease care, but start bite-sized, bring people together, build the models out. Just close with that. For example, palliative health care, to really do it right, takes coming to CMS and building a new financial model that's not strict for fee-for-service, but in the Medicare Advantage world will allow you to put that model together. Once the model works for palliative health care, chronic disease, you can expand it out through the system.
You know, we've learned a lot in California about how to make the ACA work. And so, you know, premiums on covered California have been in single digits really throughout the time that California implemented the ACA. And so I think it's just worth highlighting what allowed that to happen. What are the conditions that in California have allowed premiums to grow at a much slower rate than really they have in other exchanges elsewhere in the country? Two of those that are really important, and that is outreach, and spending the money that it takes to go during open enrollment and have people who are eligible know about what's available and getting that coverage. And I think that, and telling the message about if you choose not to be covered, you do put yourself financially and your family financially at risk, and really kind of drilling that down. That has really created a culture of coverage in California. People now understand what open enrollment means. And even as the feds have dramatically reduced outreach dollars, something to the tune of $10 million, Covered California is spending upwards of $100 million doing direct outreach to try to create that ongoing sense of coverage, which then allows you to have a much larger risk pool, which then does allow you to have some negotiating power with plans. And so I think it's really, you know, reinsurance was talked about this morning, and there are certainly, you know, all the nicks that have come at ACA. But I think mostly what we've learned is that you can keep premiums down if you can keep people in to coverage. And, you know, people churn through that appropriately so. They get employed, you know, they get a new job, they get employer-based coverage. That's great. They've learned about coverage. So that's one. And the second thing I would say, I should say I'm on the board of Covered California, so I'll disclose that. But the second thing I would say is that as an active purchaser, working with plans to sort of begin to look at things like palliative care and what are the outcomes we're trying to reach in reducing disparities and the like, and working in partnership between the exchanges and the plans, 11 plans in California. So I would say that affordability does come with getting everybody in, which was a tenet of ACA. And so again, I'm assuming we're not going to get some big new health reform, you know, we're going to have a split Congress and the like. But I think we should learn from those exchanges that have been quite viable and that have kept rates down. Now, as you know, there was a single payer bill was introduced in California. It promptly got tabled in committee. But what it generated was a select committee to begin to look at, okay, what subsidies do you use at 400%? And really, how do you sort of thinking about softening those bridges that were talked about earlier today?
People who are getting hammered.
Exactly, people who are getting hammered.
Right.
So, you know, that will be on us to look at. States potentially deciding themselves to do some version of requirement for having coverage is another thing that we're now seeing. California will surely look at that. So my whole point here is that affordability was built into the ACA if all the provisions were still at play. And they are not all quite still at play.
All right, well,
You
go ahead.
There's one other issue after the senator mentioned end of life. It's a bigger bite, and it probably would have to come after a smaller bite like he's talking about, but it's the whole opioid crisis situation. You know, you talk about an issue that seems to be rather bipartisan in terms of people buying in to doing something about it. I mean, you still have people arguing about a little bit about, you know, they don't deserve help because they've made a bad decision. But I think for the most part, we're coming to that point of everybody saying this is a disease and we really have to do something about it. And of course, it's no respecter of persons. it affects the wealthiest as well as the poorest families. So, something around tackling that issue might well bring some bipartisan effort and a wraparound kind of approach to the social determinants, because, the treatment and getting people weaned off of drugs and then turning them right back out, and they don't have proper housing, they don't have enough to eat, they're in the same environment. We've got that vicious cycle going. And so that would be another area that we might be able to do something.
Jay, could I just both Senator and Governor both mentioned palliative care. Hartford Foundation, California Healthcare Foundation did a big survey. This falls into the spirit of, if you ask people what they want, you actually hear what they want. And what we heard overwhelmingly was a desire for palliative care services, if you unpack it and describe it what it is. And so I think this is one of those things where we're very much behind where our families and our communities and patients really want to be as it relates to accessing palliative care, team-based care, to be able to take care of end-of-life issues and the like. And similarly, we surveyed clinicians who likewise said we weren't given the tools to be able to talk about palliative care or hospice care. So I think we have a lot of work to do in this country. It's something that is really quite driven by patient interest and family interest, and we don't yet have it packaged. We haven't done the training programs for it. There's just a lot of opportunity, as the Senator and Governor mentioned, on palliative care, I think, in the country. I
think one of the big issues is that we don't really have a healthcare system. Most other countries have this far more formalized and regularized. We have an extremely ad hoc system. And Senator, you kind of alluded to this already, but it was already my next question. Bipartisanship, when I first started covering healthcare in the 1980s, was the norm. Actually, the partisan fights about healthcare were the exception. It was mostly Democrats and Republicans working together. That has obviously diverged. We've now seen the term primary become a verb. So, Democrats and Republicans tend to, even if they want to work together, tend to, if not retreat to their corners, get dragged back to their corners. How can you, is there a way to overcome that in something as big and as clearly important to everybody, to Democrats and Republicans, as the state of the healthcare system?
I think so. And I think obviously the U.S. of care, I think as we go forward, it's very important for us to be sort of nonpartisan, bipartisan, encourage the discussion back and forth. The partisanship is going to pass, even though the red got redder and the blue got bluer. So I keep saying this, and people, yeah, that's right. The polling data shows that the things were aggravated. But there's some good signs there. In the midterm elections, as was implied today, was the greatest turnout in the midterm elections in the last 60 years. People care. People care. Again, I know they got more polarized because that's the next bullet down, but people care. And as people care, the health care issue, for the first time, I went for months and months debating and talking, saying health care is not going to be a big issue here. It never is. And it never is historically until we have it today. As we hear talk about patients and families and dinner table and engagement, which I agree with 100%, and then we have this other thing that people politically begin to care, that gives a huge opportunity today to capture people around health and around health care and have it bubble up. It's not going to start in the Capitol right now. Tom Dash, when I was majority leader, Tom Dash was Democratic leader, I was Republican leader. We had debates. We spent time together at night and that sort of thing. So that's changed a little bit now. But now here, 20 years later, 15 years, how old are we? 15 years later, 18 years later, Tom Daschle and I have written 25 articles together. Tom Daschle, Bill Frist in Politico, The Hill, New York Times, LA Times, Washington Post. We've written 5 bipartisan op-eds in the last 8 months. We've written, I think, 27 in the last 6 years. I think there's going to need to be more of that, where U.S. of Care, and there are other groups out, the Bipartisan Policy Center, which is sort of also active here. Kaiser, you up here, where you have a voice that it doesn't have the partisan filter, gives us a great opportunity. We have greater turnout, greater interest in the midterm election ever. Healthcare, the number one issue. The health literacy, which is what the individual engagement California does well, our federal government is running from, which is something to learn from. I'm optimistic underneath. I'm literally optimistic underneath.
It's going to have to start at the local level, though. I mean, we need leadership like he and Senator Daschle are doing, and that is so important, just to be seen with your names on the same thing. I mean, these days, isn't that amazing that we get all excited because, a Democrat and a Republican actually co-author something? But the more this can bubble up from the state and local level, I think in the long term, that'll change the way people act up here of necessity. I think some folks up here got their eyes opened a little bit over the last 2 or 3 years, and it was on health care because we made it such a partisan issue. And then, they end up passing or wanting to vote on things that was going to take coverage away from 20 million people. And so all at once, when they went home, people were paying attention. I mean, folks never pay much attention to what goes on up here, but they started paying attention because, oh my God, you're going to take my health care away. And I think it was both Republicans and Democrats coming to those town hall meetings and saying, wait a minute, I don't know what you call it or what you want to do, but for God's sakes, don't take my health care away. A very simple kind of thing, but it got everybody's attention. And I think the more that on a local level, like U.S. of Care is doing, innovating, getting states to come up with innovative ideas and everything, that will bubble up. And I think the Senator's right. It's not going to happen up here. It's going to have to come from kind of the outside and from the bottom up. But the more that goes on, I think eventually healthcare is going to, move back more toward a nonpartisan issue, and we'll be able to get some things done.
In California, you've got the Democrats by themselves
Bluer than
who are
blue.
completely divided.
Bluer than blue.
Yeah.
I mean,
Well,
first,
it's the blue versus the blue, though.
so first, it's worth noting,
Yes,
we did the ACA during a Republican governor. Schwarzenegger really put the team together that did that. So it was a Republican governor working with a largely Democratic legislature. So just to note, that's how we got started, and I think worth keeping that in mind. There will be all kinds of who's left of whom in California and how far do you go and how quickly do you go. I think it will raise a conversation quite quickly about how do you think about recession-proofing a Medi-Cal program that serves 1 out of every 3 people in the state of California. When we talk about Cover California being very successful, there's only 1.5 million people in that. There's 13 million people in the Medicaid program in California. And so I think there is going to need to be that conversation, which I think that the legislature will want to have and will have. The advocates will have their say. We have a robust community input, community engagement. We have amazing health advocates. The unions will have a lot to say in California, obviously, and will continue to drive that conversation. I do want to say this morning it was mentioned how important the Republican governors were in protecting the ACA. And it's worth noting that California Healthcare Foundations recognized how important governors were outside of California who expanded Medicaid to California's Medicaid program. And so in that regard, really tried to share
In what way?
data and evidence, doing the math, helping people really understand what are the economic impacts of expanding Medicaid, or if you don't.
Exactly.
And that was really important to governors who were on the fence and trying to decide what to do. We had the ability to commission that research, to do the data, to sort of shed light, both on what we had done in California but elsewhere. And I think we have a responsibility as a big state with a big Medicaid program to be able to do that, to be able to help the conversations that's going on in other states.
When I got ready to implement expanded Medicaid, I knew that the argument was going to be it's going to bankrupt us. We can't afford to do this. And so I brought in PricewaterhouseCoopers and asked them to do a study. What do you think? Make projections of what this is going to do to us and for us. And they came back in about 6 months and looked at me and said, Governor, you can't afford not to do this. because it's going to create 17,000 new jobs over the next 8 years. It's going to infuse about $15 billion into your economy that you haven't had before, and it's going to have a positive impact on your budget. Well, that was pretty good. I like that. And so I went on and expanded. But then a year later, I brought in Deloitte Consulting and said, okay, now we've got a year's actual numbers. And I want you to take the PwC report and take the actual numbers and tell me where we are and how it's going. They came back in and said, well, PwC was wrong. They weren't optimistic enough. Because, they told you were going to create 17,000 new jobs over the next 8 years. You've created 12,000 new jobs the first year of this. And instead of, $15 billion, it's going to be $30 billion infused into your economies. But those are the kinds of things. When the NGA gets together, the National Governors Association, we have governors-only luncheons. And it's amazing, folks. We actually talk to each other, regardless of party. We sit around, we talk. And I had several Republican governors say, would you send me those reports? I mean, this is the kind of information we need to show that this is not just I'm a do-gooder. This is going to really benefit our economy, and overall, it'll move our state along.
So, Senator, you already brought up social determinants of health. I want to circle back to that, and sort of in the vein of what Governor Beshear was talking about, we've gotten to the point where people don't believe research anymore. I mean, how do you sort of educate policymakers, the business community, patients in why, as you said at the beginning, access to medical care is not the be-all and end-all of health? I mean, how do we sort of make that jump as a society to looking at the bigger picture and calling that health care rather than just what happens in a doctor's office or in a hospital?
Yeah. There are organizations like the Robert Wood Johnson Foundation who made a major shift about 3 years ago, recognized early on that the government's not going to be the source of the information. And in this current environment that maybe it's social media, but where President Trump and the fake news and all, the distrust of everything, institutions, Congress, Wall Street, everything. I mean, really comes back to how do you engage today? If the thematic that healthcare is important, being a surgeon's important, the hospitals are important, but the behavior and the interpretation, what's going to actually affect the behavior, it's no longer Bill Frist in a white coat, transplant surgeon coming in and saying, you need a heart transplant, we're going to do it, this is what you need to do. That doesn't work. The behavior end of it, and this is, again, I'm a little bit maybe too hopeful, is going to be influenced the peer-to-peer. And the peer-to-peer is going to be engaging peers, or it could be through social media, where people do have 20 friends and what they're thinking in terms of behavior. Smoking is a huge issue in Nashville, Tennessee. Nashville is probably one of the top 3 hottest cities in terms of attracting young people, new restaurants, creative people. Unemployment's low, taxes are low. Everybody moved to Nashville. But our population health, not healthcare, is poor compared to Charlotte or Austin or Cincinnati or Raleigh-Durham or Fort Worth or Dallas, cities that we're competing for. So then all of a sudden you get this local competition in it. Well, why do more people smoke here? Why do we have less parks, fewer sidewalks? Why is our obesity rate higher? Why do we eat more Hattie B hot fried chicken, which is why a lot of people come? But the why of that. And that sort of answer is not decided in Washington, D.C., and it's not decided by policymakers or where we think the solutions are. It's decided by local communities and groups and discussions. The old knitting clubs in Appalachia, sort of where we're from, where a group of people come and, once a week just knit together and they talk, and then all of a sudden that becomes the talk of the community of 3,000. Social media gives us that. Now we have everything that's going on with social media and the problems there, but again, we have a tool today that can accomplish what Washington and even governors are not going to be able to solve. To marry this concept of the 20% of impact of health is what we mainly are talking about, but the 40% is behavior and whether we wear our seatbelts and whether we smoke and what we eat and how we live and where we work and play and the like. And that's going to be really coming back to the engagement, whether it's formal engagement or health literacy or just where you get your information from. We have to inject there.
So go around policymakers and just go straight to the public?
Yes. Yeah. Well, I think the fake news thing bothers me a lot, and you introduced it. The vaccination now, there's a huge around the world, in France right now, in Italy, in Los Angeles, where people are not getting vaccinated. And that's a basic health literacy. It started with science, true fake science with autism, and that one paper 20 years ago that was disproven 12 years later. But from that, there's a huge distrust of science today, of good science. And if ultimately we're measuring outcomes based on science and scientific principles, if you distrust the basic science. So that's a huge issue, the sort of anti-vax movement, which represents the anti-science movement, that I think leadership does have to stand up and support over time.
Well, you guys answer. You guys can be ready with your questions. There are microphones on each side. Social determinants of health?
I agree with it. No, you know, it's a huge issue, and when you start thinking about how you're going to address housing and hunger and you know all of these things that come together or smoking or wearing your seatbelt, you know, it's a big issue, and I'm glad that I think in Minnesota. And in California and some places where those discussions are going on, my guess is that they're going to lead the way and not Kentucky in that area, because we're still struggling just, you know, to make sure we have our health system in place and trying to figure out a way to attack the opioid crisis, which is destroying a lot of lives.
At the federal, because the state level is important, but at the federal level, just I got to put it on the table because I kind of been saying the federal level doesn't have solutions. Things like in Medicare right now, in Medicaid, the importance of food, which is basic, what we put in our bodies in terms of the healing after surgery. And if we send people out after 2 days instead of 4 days and they're living by themselves and fast food is there in their area of gangs, all of that's the social determinants, but they bounce right back in the hospital. And so the fact that for the first time in really the last 24 months, both especially Medicare and Medicaid are beginning to think about and open up, especially to Medicare Advantage, reimbursement for food. In Medicaid, in the private sector, I invest to help put together a company that is one of the largest, it's like Meals on Wheels, but it's in 25 states and 35,000 meals a day to the Medicaid population, good, healthy food. So there are ways both in the private sector and in the public sector to begin some reimbursement for things that determine outcomes like food, and that is being included in our Medicare legislation or proposals today.
Smith's got a question.
We answered it all.
No, Sarah has a question. Wait for a microphone. Yes, so our streaming audience can hear, and please tell us who you are.
Hi, Sarah Dash, again with the Alliance for Health Policy. Thank you all so much for the panel. And Senator, this question is for you, but I would certainly love to hear what everyone thinks. When we talk about the social determinants of health, you know, the institution of the Congress and to some extent the agencies is kind of divided into like the healthcare financing, you know, the finance and ways and means, and then the sort of public health committees, you know, and a lot of the things you talked about, Meals on Wheels, are dealt with in the appropriations. And I just wonder if you have any insights or thoughts as to how the institution itself might need to evolve and kind of work together a little bit better to address some of these concerns.
Yeah, it's a great point. As everybody knows, in the Senate there are 2 health committees, and then the boundaries are sort of artificial, but they're pretty discreet that you have to operate by. And then you have to pull those committees together. There's competition between the committees. Yeah, exactly. Yeah, exactly. And then there are 3 in the House. So it's a great question. I wouldn't bet that's going to change very much until we build this sort of groundswell. I will say that the opportunity outside of that to push the social determinants, and that very quickly takes you to the co-equal branch of government, and that is the executive branch. And again, everybody has different opinions of what's going on all over government itself. Just personally, having worked with, you know, really 3 presidents in some shape or form, The people in HHS now, I feel really good about the approach, both the public persona, what people see, but also what they're working on. And they're thinking social determinants. They're thinking how you do it through not necessarily legislation, but through regulation. So I think if I had to say, let's all get involved and look and talk and discuss and impact government, I have a lot. I think the leverage, the impact will be much greater at the CMS area and in the expanded area where people can listen. You can go in, you can put science on the table. You know, private companies like many that I have will take data in and say, this is the data, this is the real world experience. It's not sort of Harvard, sort of Ivy League sort of stuff going on. And that's where I think a lot of the action is today. But I think your point's a good one. We need to think about how should the institutions within the Senate and the House change over time. I don't think they will very much now, but how should they?
Either of you want to add something to that? No.
He's the one that served there.
Next question. Are you over here? Anybody?
There's a question back there.
Mark Pauley from the Wharton School. So, Senator Frist, I think this is a question for you. Palliative care seems like a good idea. It's always been a puzzle to me why some Medicare Advantage plan doesn't emphasize palliative care. Are there some regulatory impediments to doing that, or is it just a failure of imagination? I'd certainly want to sign up for one, especially if it was run by nurses too. What's stopping people from emphasizing something that seems so obvious?
You know, well, it's interesting. And the palliative health care, like all of these, because we want to solve things overnight, it's just hard to do. It's hard to do it at home. It's hard to do it anywhere. Palliative health care movement really started with, I don't want to say where it started, but the Robert Wood Johnson Foundation about 20 years ago. And George Soros, actually, he's been in the news lately, put a lot of money into it. And with that, the discipline of, it's a terrible word, palliative health care. On the other hand, I still use it a lot because it gets you away from, it's totally different than hospice, and it's different than acute care or chronic care. It's just different. So I keep using the word itself. And then you had to invent the field, define it. Why is it different? And it's totally different. We won't go into that, but totally different. You're still treating. Hospice, you've stopped the actual physical treatment. Both of them have mental, both of them are team-based, both have mental, spiritual, social treatment, but it's a totally different field. And then you had to take it to the medical schools for the first time ever and teach the trainers, or teach the people who be providers. And you're right, nurses are really run palliative health care. So when I say the doctors, it's really the nurses, you're exactly right, that are coming in. And then you have to set up a reimbursement of some sort for that. And that's where we are today, the sort of breakthrough where you can get a team of people responsible for one individual instead of fee-for-service, chaotic, no system, as Judy said, coming in. To put a team together, you have to figure out how to reimburse the team. So that takes payment reform, and that does have to be institutionalized by Congress. But no, it doesn't any longer because you have Medicare Advantage. And Medicare Advantage strips away a lot of the old regulations and gives a group of plans the flexibility. Say, here's the money, you implement this. So how many people are in Medicare now? 50, 60?
55.
55 million people are in Medicare now. Half of them are in Medicare Advantage. You can get good palliative health care there now. It is value-based. It is better outcomes. It is living longer. It is living more fulfilling lives. All of that's been proven. The other 25 million people in fee-for-service can't get it at all. They can't get it because they're still fee-for-service. It's fractionated. Now, you can get it if you're in a hospital, you know, while you're in the hospital, maybe for a few weeks after. So right now, our policy's got Medicare Advantage where you have this flexibility. All of them give some sort of palliative health care, just about all of them. I've contracted with probably 10 of them, of the plans. It's the 25 million people who have not yet been, in my mind, modernized, and they don't have access to palliative health care today.
Great. I think we have time for one more question, if it's a quick one, there in the back.
Hi, Dave Grandy from Penn. Social determinants of health. There's been a lot of discussion, and I think there are opportunities where you can get people coming together from the two parties, but then there's also times where people really deviate sharply. And so it's easy to talk about social determinants of health in the abstract. And I'm wondering if I just took an example in Philadelphia where I live, There's a lot of work done on tobacco right now, and the Department of Public Health has tried to restrict the number of outlets selling tobacco products, for example, and that's set off a whole political fight with the state. And that's really looking at the environment of tobacco sales. And so there it gets very political. It's a real dogfight. So when we're talking about social determinants of health, like what are the places to start from where there really is not this partisan line that emerges?
That was what I was trying to ask. He just asked it better.
Yeah, I mean, I actually think that the environment makes a ton of difference, and really sort of thinking about those things that most negatively impact people's health that are very prevalent in their community. I mean, sugary drinks, we've had that battle going on in California and counties. Some counties have passed it. It's never made it out of committee in the legislature, and completely Democratic legislature. So, but I do think it's important to think about what the environment is that is around some of these determinants that then the healthcare system ends up spending a tremendous amount of money on the back end managing chronic diseases to be able to do that, and making that connection in policy environments is really important to do. You need evidence and data to be able to do that, and you need really strong advocates for it. We've done much better on tobacco. I mean, very much not like other parts of the country, very, very low smoking rates in California. But that was, we taxed cigarettes and sued the tobacco companies. I mean, really, it was a multi-pronged approach at doing that. And I think when you look at some of these very enduring toxic things in the environment, you need to be able to have multiple levers to go at them and try to address them.
I've spoken to, kind of in my rambling, several food. I think instead of coming in and shutting places down, that there are better angels out there, better incentive, better things to appeal to. Food deserts right now, my example, is an obvious place where policymakers planning and appeal to the private sector in partnerships coming together, where you don't have a 12 blocks by 12 blocks in a tough neighborhood where you have no access to fresher food, better food, healthier food. There are social determinants in neighborhoods, coming back to geography, of looking where people come into emergency rooms between 12 and 4 o'clock. If you have that data and record that data and you see where they actually come from, to focus on that part of the city in terms of a free health clinic. There are a lot of both churches and nonprofits who have these clinics, but typically they're not located, and to give some assistance to do that. Transportation right now, the biggest impediment for women getting mammograms, just for example, it's not cost, which we all, to get the cost down, everything's going to be okay. It's not access in terms of, you got it in your plan. It's having a woman be able to go across town to get a mammogram and transportation. And there are simple, low-hanging things, whether it's Uber or Lyft or however it's set up, a transportation that's set up that could do more for breast cancer than making mammograms free for everybody. So it's that kind of thinking that we just all need to be doing when we talk cost and we talk access. And we've built into it, the U.S. Care's built into it. If you listen to Andy or you look at principle number 1, it's framed pretty much around the equity issues. Equity scares some people, so don't just throw the word out to anybody. It depends on some people. Again, in my part or our part of the country, you start talking about equity all the time. They don't know, what does that do? But the fact that's built into the principle, I think, gives you a lot of cover in terms of what we're talking about. It's not just the second principle, cost. And the access issue, you have to tie the equity into it. And that's the kind of social determinants that if we really want to improve outcomes, we need to be addressing at the same time we're doing our traditional access of a health care plan or cost itself. Build those social determinants into it.
All right. You want to add something real quick? We're out of time.
All right, back to the magic wand for a moment. If I could wave a magic wand and do one thing in Kentucky that would change people's health more than anything else, it would be smoking. No question about it. We've got pregnant women smoking. It's a mess. But we've come a long way, and we're a tobacco state, just like you all were to an extent in North Carolina. But but over half our population now is covered by smoking ordinances, but we can't get a statewide one passed. But I think the senator's right. Finding positive types of things, even small things that you can do and affect one of those social determinants is the way to go, because it's so much harder to try to tell somebody they can't do something than help them to do the right thing for the right reasons.
Julie, before we wrap, so Senator talked about equity and the concept of health equity and some people being uncomfortable with that. What does that mean? And I just think we ought to name that for people who hear equity and get defensive, there's a sense of you're going to take something away from me and give it to somebody else. And I think it's really important that we take that myth that that is not what we're talking about. We're talking about health equity. Yeah. That really what we're talking about are basic things: transportation, food, safe housing, and that we want everybody to have that. And I worry that we talk about equity and people sort of say, well, that means I'm taking from here to give to that. And I just think we have to get rid of that myth if we're going to continue this conversation and, importantly, make improvements in health equity.
Thank you. What a wonderful panel.